and that being in equilibrium with the free amount. Okay? So this protein that binds it has a particular name. It's written down there for you. We call it TBG, but it's thyroxine binding globulin. Very, very few. Look at, it says about 75%, but you're talking about, look down there at right underneath that. Total T4, bound and free, is 4.5 to 12.5 micrograms per deciliter. See right below that? Now look at the free. Look at the amount of free T4, 0.7 to 2 nanograms, 1,000-fold less, per deciliter. So very, very little amount of that most of it's bound. Okay? So if you do anything to change that binding hormone, or binding globulin, you do a lot of change with, you have small changes in the free and it'll be big. So in pregnancy, she told you the amounts go up, right? Because that binding hormone goes up in response to the hormones that are present. There are other diseases where that will go down. There's other diseases where that binding globulin goes up. So that this concept is important to keep in mind. So get a little bit of T4 and a little bit of T3, and that is the physiologically active. And so that's the part we're most concerned about. So that's why so you didn't hear many people talk about ordering total T4. So most will order a free T4. Okay. Let's see. So TSH normal limits are going to be pretty close to this, 0.4 to 4.5. Your different assays in your different labs will have slight variations. Your T4, 4.5 to 12.5, your free T4, 0.7 to 2. So, thinking through, one of the things you should think through for TSH and T4, that's the two we'll concentrate on, is what is it like in the pathologic state, okay? And then what happens when we correct them with hormone, okay? And one of the speakers said it, you just kind of have to think through it, and where are you? Which organ is the problem, and what am I correcting, okay? And that's where it just, you just have to think, if you do it all the time, it's not a big deal. But if you're only coming at it every once in a while, just remembering all those relationships we talked about will be helpful to you. Okay. So let's start with hyperthyroidism. We talked about Graves. So this is an overproduction of thyroid hormone. Get too much and we call it toxic because it makes the person really sick. And it can kill them. So in Graves, you've got an autoimmune disease. You are putting the antibodies against that TSH receptor. So this is one of the times when an antibody sits on a receptor and it makes it work. We don't see that as often. Okay? So when that antibody attaches to that TSH, it just keeps putting out more. It's like TSH is present. So the thyroid hormone responds and it just starts putting out more and more T3 and T4. So if you're stimulating that thyroid with a lot of TSH, what happens to the size? It grows. It's bigger. So Graves, also known as toxic diffuse goiter. So what does that mean? What's the diffuse mean? The whole gland, and the goiter tells you it's a big gland, right? Most common cause are those TSH receptor antibodies. The other one she talked about was a toxic autonomous nodular goiter. So what does that mean? The nodular goiter means what? The goiter is what? It's large gland. What's the nodule?
It's in specific areas.
It's a specific part of the thyroid, and it's autonomous. So what's it telling you? It's doing its own thing outside of the normal regulations that are put in place by the body. Toxic because the levels of T4 and T3 are too high. So that's the second most common cause. The third is exogenous thyroid excess. Okay? So these diet clinics that give people thyroid hormone to help them lose weight, this is a common place to see this. So we'll talk about it a little bit further down. They come in with thyrotoxic symptoms, but there's no eye changes, and they have no goiter. So when you see that, you have to start thinking, what are you taking? People get it from their friends, somebody dies, they take the thyroid and keep it and take it. They go to a weight loss clinic and they get big doses and they take that. Not uncommon. It's also called factitious hyperthyroidism. Iatrogenic, so this is iodine administration, for maybe they're getting it for another treatment. Amiodarone, we talked about, amiodarone has a lot of iodine just as part of the makeup of the drug. And then interferon. So this just gives the thyroid lots of raw material, so it just makes hormone out of it. So those are your four big common causes. So with Graves', if you look under signs and symptoms, those are things that have been brought up before, so these are the more toxic, so the nervousness. One thing I notice about people who are hyperthyroid, it's just speech that it's like a manic episode. It's just pressured speech that just comes at you. They're very, very heightened awareness, heightened speech, heightened thought. Weight loss in face of increased appetite, anxiety, heart rate can be pretty high. Tremor, emotional instability, easy fatigability, muscle atrophy, many different. Not everybody presents with everything. Excessive sweating, heat intolerance, preference for cold. Goiter is listed down there. Gynecomastia in men. So next week when Dr. Vanetta talks about hypogonadism in men, we're going to have a list of things for you in terms of gynecomastia in men. You really need to think about it because it's not normal. It's not a normal state. So what is causing it? And this is one of the things that can cause it. In people over 60, the heart and the muscle complaints will be the most common. And in kids, it's rapid growth. The eye changes, if you look on the next page, and you've been shown these pictures, most people are familiar, the exophthalmos. So what happens in that disease is you get these glycated proteins that deposit in the eyes. And once you get those types of glycated products, you just can't get rid of them. The body can't get rid of them. And so they deposit, and that's what they start to change the architecture. The ability of the eyelid to close is one of the big things. So that is the reason behind that. Depositions of glycoaminoglycans. Okay. So lid retraction, you see that on the other side. The periorbital edema. And what did she tell you if one eye bulges more than the other? What do you rule out a tumor? Okay. Redness in the conjunctiva. These folks cannot shut the eye fully, so they suffer from tear. They suffer more increased risk of infection. So all the things that the tears do for you do not get fully done for them. And they're assaulted by what's ever in the environment. It keeps coming at their eyeballs. So irritation of the cornea, loss in vision, fibrotic, fail to relax. The cardiac symptoms, AFib. Whenever you have new onset AFib, what the doctor's always going to do is they're going to order and do thyroids. They're always going to rule that out because it's a very common cause of new onset AFib for whatever reason. So that is one to always look for when you're older. And it's not sensitive to digoxin, so it becomes hard to treat. So addressing the thyroid first, sometimes with the AFib then goes away or is controlled. The dermopathy, if you look on the next page, you'll see several different, you'll at least see that apopachy, dermopathies. So you get those glycated proteins again being deposited in the skin. So you get the same kind of problems with changes in, you see the swelling, you see that they get stiff, they get harder to make a fist is part of it. Clubbing of the toes and fingers. They get a change over the tibia, thickening. The nail beds can separate. So looking for those. Those are more advanced, they haven't been treated, or they haven't been under a good control. So all things that have been mentioned to some extent. Other things are listed on the next page, the alopecia, eyebrows, change in skin color. The mixed edema is the more advanced. That is a medical emergency. People can die of a mixed edema. So laboratory findings, elevated T4 and suppressed TSH. Now why is that?
This is too much T4.
So the T4 is from what reason?
Hyperactivity of the thyroid.
Due to what? The antibodies that are sitting on the TSH receptor. So it's pouring out T4. So you got that negative feedback. So the pituitary is like, they're good. Can't do anything about it. It can't shut the gland off, but it can quit putting out TSH. So elevated T4 and low TSH. So you should be able to recognize that given a patient's scenario, it would be a very good lab medicine question is why is that? What's the cause? Most likely cause. Okay, treatment. So the main treatment, there's several things. First of all, we want to control symptoms because they are usually uncomfortable. And if they're older, then we need to get that heart to settle down. So there's symptom control, and then what we're trying to do is decrease the amount of T4 and T3 that the thyroid is producing. And we'd like to get them to remission. We may be able, if it's a mild case, we may be able to get them to go into remission and stay there. Or we may not, and we may have to do some type of ablative therapy. So with ablative therapy is your surgery or your radioactive iodine. We can put them in remission, and we can do a mix. You can do antithyroid medicines for a while with a beta blocker, and then go on to radioactive iodine, or you can go to that first, and then they talk to you about the perils of surgery. So it's probably going to be a latter move. So symptom control, these are the beta blockers. If you have somebody who cannot take a beta blocker, then they would do a calcium channel blocker. But most people, you're going to see this more in young, so most of them will be able to do a beta blocker. But if not, and they've got contraindications, then a calcium channel blocker. So this is symptom control only. It does nothing to the thyroid. It doesn't cure it, doesn't stop anything, it just simply controls the symptoms they're getting. So you want beta blockers without intrinsic sympathetic activity. That would be bad. Like Pendolol. Those are drugs we don't use very often. They're not the more common beta blockers. So if you stick with the propranolol, been around forever, cheap, doesn't require multiple daily dosing, but I like it because you can more fine-tune the dose. Tenolol, usually once or twice a day, metoprolol or nadolol. We use them in thyroid storm. You have an IV beta blocker, esmolol. It's very, very short acting, so you can turn it on and turn it off and stop the action. You can do it to get patients ready for surgery, so you won't want somebody tacking along at 120 and take them to surgery, so another reason to use it. Pregnant patients, we can use that have thyroid toxicosis, so it's safe then. Primary therapy is for thyroiditis or iodine-induced hyperthyroidism. So symptoms will go down usually fairly quickly. It'll be a gradual change. So the nervousness, palpitations, fatigue, weight loss, excessive sweating, heat intolerance, and tremor. So that's a lot of what people will present with. It can be controlled with the beta blocker. Propranolol also has the ability to, in small amounts, decrease the conversion of T4 to T3. It's not a huge effect, but the other beta blockers do not have that. So that effect is slow. It's a 7 to 10 days. Doesn't contribute much to overall effect. So the dose is, starting dose, 20 to 40, 4 times a day. Patients may feel better with that to start with. The goal is under 90. What's a normal heart rate range for an adult? 60 to 100. So we're just going to take them down to the upper limit. You don't have to take them down to 60 to 70. We're not treating heart disease like we do when we're treating beta blockers with hypertensive disease or congestive heart failure. So it's a very different approach. We're just trying to keep the adrenergic response down. Younger and very toxic patients, so you see that you can go up to 240 to 480. Atenolol is 25 to 50. You can go up to 200 milligrams a day. We rarely use those doses in any other cardiac disease. As soon as you make a diagnosis, you can start it. Okay? You're not going to hurt them. If they've got a they're tacking away, then you're not going to make a mistake. Your contraindications, you've seen this before. If we could put a little emoji here, it would be that little emoji with the eyes open and the mouth. It's like, you've seen this before. Okay, decompensated heart failure, asthma, COPD. Now, propranolol is not a selective, so you're going to have trouble. So if you've got somebody who's got mild airway disease, you would go with a selective beta blocker. Out of that list I gave you, which one is a selective beta blocker? No, propranolol is non-selective. Metoprolol, lower end, beta-1 specific. So again, second or third degree heart block, bradycardia. Again, I should be able to wake you up around sleep and you spout these off to me. You've seen them 100 times, so you ought to be able to click them off at this point. Usually used with the thioamides. So the thioamides are the anti-thyroid. That's methimazole and PTU. That's their classification. They're thioamides. You can also use them with radioactive. So she talked about thyroiditis after getting radioactive iodine. So you can use it for a few days while they're kind of dumping all their stuff out of their thyroid. If they are contraindicated, you can use diltiazem. Questions about that? So the other thing, in order so that's symptom control. In order to get the thyroid to quit doing what it's doing, we're going to use the thioamides. That's the anti-thyroid drugs. Radioactive iodine and surgery will also do those, but those are permanent. Thioamides are reversible. No consensus, she told you that, no consensus as to what is best. It would be more of a patient option. She told you that in the United States, radioactive iodine is usually the one that physicians prefer. I don't know if that's what patients prefer, but that's probably the way they're going, the way maybe the doctor has or has informed them, or the surgeon. But all of those things need to be discussed with the patients. The pros and cons, every one of them have major consequences and major benefit. And they're not mutually exclusive. We use them sometimes together. We may use antithyroid drugs or thioamides before they get radioactive iodine in terms of decreasing the activity of the gland, or before surgery. So these are usually used in some type of combination. The The thioamides are usually long-term, so think long-term with them. I think average is about 18 months in this country. Now, she told you, I remember it was Japan, they use them 5 or 6 years on average. You can use them indefinitely as long as the person does not have bad reactions. They do have some very nasty, sometimes fatal reactions, but those usually occur early on, and if you are monitoring those, that you would find them early. Let's see. So radioactive iodine can be given as initial therapy. These can be given as initial therapy, or what was I saying? Radioiodine may be given as initial or after pre-treatment. Oh, okay. So radioactive iodine, using it initially, right off the bat, or after you've used thioamides. So either way. Anti-thyroid drugs are used, that last bullet is important. Anti-thyroid drugs are used to attain a euthyroid state before surgery. So you want them euthyroid before that surgery is done. Okay, then this goes through the choice of different, just kind of gives you some different scenarios to see how these things are used. So if they're having significant, under choice of treatment for hyperthyroid, first bullet, if they're having significant symptoms of hyperthyroidism, and what would those be? Fast heart rate, tremor,
Heart palpitation.
Symptoms, not physical signs, but symptoms. So heart rate you talked about, tremors, what else? Fatigue, muscle atrophy, arrhythmias. So if they've got significant symptoms or they're at risk for hyperthyroid complications, so that would be AFib would be one of those. Start a thioamide with a beta blocker. They'll get symptom relief pretty quick. Then they could be followed by ablative therapy if that was a choice. So they could do the RAI or surgery. Or they can take the thioamide for a couple of years and see if they can stay in remission. So like a lot of things we do, we did this with Crohn's and UC, our goal is to get them into remission. Or they could take it for a long time, years. So multiple options. Patient factors, mild, look under the last three, mild hypothyroidism, minimal thyroid enlargement, no orbitopathy. So this is very mild hyperthyroidism. So maybe radioactive iodine or 1 to 2 years of thioamide. For people who have more symptomatic but still mild disease, so mild hyperthyroidism, mild or minimal gland enlargement, mild orbitopathy. Again, radioactive iodine or thioamides, good options. More severe hyperthyroidism, then definitives, either radioactive iodine or surgery. Could do the 1 to 2 years of thioamides or long term. So see, they fit almost every. On the very next page, moderate to severe orbitopathy, surgery rather than radioactive iodine. So most of the people you're going to see, surgery is going to be a very limited option. Okay, so let's talk about the thioamides. So there's two of them, Methimazole and PTU. They have been around forever. So everybody calls it PTU. It's propyl thyrouracil. That's what it stands for. The goal of therapy is to make them euthyroid. This takes up to 2 months to achieve that. The preferred treatment for children, pregnant women, young adults is the thioamides. And for them, it's usually depends on what how pregnant you are, what trimester depends on the drug. It's the only treatment that leaves the thyroid intact. So the consequences of taking radioactive iodine in surgery is what long term? hypothyroid. Almost everybody will move to hypothyroid. But they do not cure. But they're very effective in controlling the hyperthyroidism. Mechanism of action, what do? Well, they inhibit the biosynthesis. So they cut it at the quick. You just can't make any more. They severely decrease it. They don't make them hypothyroid, but because you're going to follow that along. But you can block out enough synthesis that you can get rid of you can bring their T4 back to normal. Now, because that gland has 2 months of hormone in it, that's why it's going to take a while to see that. So underneath it gives you a little bit more. So these are preferential substances. So what they do for the enzymes that usually iodinate that tyrosine residues, they will preferentially take up this drug, lithiamide. And they'll try to send it through the process instead of thyroglobulin and tyrosine residues, okay? So they just go to a higher priority, so the thyroid will keep working on them instead of the thyroglobulin that is available. They also divert iodine from iodination, so a second step. Third is they prevent MIT and DIT from coupling, so they prevent the production of what? Which one? T3. Okay. So see, they've got multiple, that's why they're so effective. They've got multiple places in the production of those thyroid hormones that they are just knocking it out. And the last is it concentrates in the thyroid. So they're a perfect drug from that standpoint. Not so perfect when we get to the side effects. 2 phases. Initial phase, you're going to get them euthyroid, first thing. The maintenance therapy is we want to keep them, and that would be called remission. So achieving euthyroid and keeping them there is what defines remission. Okay, so let's talk about methimazole. Becky Carlozzi alluded that this is the preferred, and that's true. It's the most potent of the two. It can be dosed once a day. It does have some severe side effects. One of the problems is it's very teratogenic, so you cannot use it in the first trimester. It's mostly very early effects on the embryo. A little bit more rapid in its efficacy than PTU and lower incidence of side effects. Okay, so initial dose is based on the severity of the symptoms they're having, how big is the gland, and what's the free T4 level. So if you look at the free T4, if it's slightly above normal, then your dose is 5 to 10 milligrams a day. If it's 1.5 to 2 times, it's 10 to 20 milligrams a day. Look on the next page, if you're 2 to 3 times the upper limits of normal, then that would be 20 to 40. So look back at those T4 levels on page 3 of me. Page 4. .7 to 2 nanograms per ml. If it's 2 times the upper limits of normal, what would the T4 level look like? What would it be?
4 nanograms.
It would be 4 nanograms per ml. Everybody see that?
Mm-hmm.
Okay. All right, so the thing to take away is I base the dose on what the T4 is, free T4. The maximal blocking dose is 120. Both of them have maximum. Beyond that, you get no more effect. We rarely dose up that high. So after 4 to 8 weeks, you're going to look at the T3 and the T4. Then you can start to taper them down, get the dose down. Change the dose on a monthly basis. We're going to see this again when we talk about treatment. T4, half-life, is really important. This is what she was talking a lot about yesterday, your clinical judgment. This is what your clinical judgment is based on. The T4, or the half-life of T4 is 7 days. So how long does it take to get to steady state? 35 days at the most. You're at 90%, that's 100%. That's 5 half-lives, that's steady state. What's 90% of steady state? Is how many half-lives? 3.3. So 3.3 half-lives would be how many days? Close to that 28. It's an easier, it's a monthly, okay? So if you do it before that, you're not at steady state, you're not at full effect. It's the same thing with when you dose T4. You're not going to check their T4 until they have been on it for about 5 to 6 weeks. Okay? Because the half-life is so long. If you do it before, you'll adjust the dose and you will overshoot. Okay? That's where your clinical judgment comes in. You adjust the dose based on that, and we'll talk about some other ways to be able to determine the dose in a person when we get to the T4 dosing. So typical ranges of maintenance dose is 5 to 30 once a day. So that's great. Duration is about up to 2 years usually. And then you'll take them off. You'll see if they can come off and maintain remission. If they can make 6 months, that's pretty good. They've got a good likelihood of staying. You will follow their T4s to see if they can stay in. So there'll be folks who will need a lot of follow-up. So methimazole should be used in everybody except first trimester pregnant. So you got to talk to your women about if you plan a pregnancy, we've got to take you off. The other is that you want them to be euthyroid before they become pregnant. Women who are outside the range, if they're hypothyroid, they usually will have trouble conceiving. So that'll be one of the parts of a workup of infertility is what's your thyroid level. What the mom's thyroid level is affects the baby. If you're too low, the baby can develop intellectual. We call it cretinism. They can be severely compromised in their IQ. We'll talk about that in a little bit. So that's really important. It's another thing like pregnancy. It's really important for these women, plan your pregnancy, be euthyroid, be on the right drug if you've got hyperthyroidism, and be monitored. Because again, we're going to change doses while you're going through pregnancy. PTU you use in the first trimester, then you can switch them over. PTU, you see the dose here, 300 to 600. It's almost 10 times what we saw with methimazole. It's usually given 3 to 4 times a day, so another drawback. The number one reason why these drugs fail is that people don't take them. So non-adherence, if people are taking them, you will get effect. They're just that good. So if you're not getting the effect you want, it probably goes to their adherence pattern. It's the same thing, the same mechanism of action, same duration of time, all of this is the very same. The one time that we really prefer PTU is in a thyroid storm because it will block conversion from T4 to T3. Methimazole does not do it to the same extent. And it'll block that conversion within 24 hours. So you see you get about a 25 to 40%. So that's really important because that's a medical emergency. So preferred first trimester of pregnancy, thyroid storm, or PTU. Okay, let's look at the objectives. The objectives, again, are remission. Average remission rate is about 50%. Time to relapse is 10 days to several years once you stop. Prolonged remission, if the longer they can stay euthyroid, once you take them off, the more likely they will stay in remission. So you're going to monitor their TSH, T4, and T3 very soon after they stop taking the thioamide, within a couple of weeks. Who's most likely to have a good outcome? Older patients, low T4 to T3 ratios, small goiters, short duration of disease, no previous relapse if they've been on them before, duration is 1 to 2 years, and they have low TSH receptor antibodies. If they go into remission and can stay there, then you're going to follow them about every 6 to 12 months. Relapse plateaus around 5 years, and about 5 to 20% will become hypothyroid. Okay, makes sense? So they're going to decrease. If you can keep them euthyroid, that's because they've got a permanent decrease in the production of those T4 and T3. Okay, so let's look at what you do monitoring-wise. This is really important. 2 things you want to know before you start them is CBC and liver test. Mostly, you're not looking so much, with liver you would be a little bit more hesitant to put them on these drugs if their liver enzymes are already elevated, but mostly you need a baseline to compare to. So agranulocytosis, most serious of the complications. It occurs into a mild form that is transient and will usually resolve on its own, and a more severe form that can be fatal. So PTU is the drug that tends to be more likely to do this. It is still a rare event, but it can occur. So it concentrates in granulocytes, so that's where the problem comes from. It's characterized, and these would be the symptoms that you would tell your patients. If you have these, if you develop these, you need to call my office, or you need to go to the emergency room. Fever, malaise, gingivitis, oropharyngeal infection, granulocyte count, they wouldn't know, less than 250. So prevalence up to 6%. Higher risk patients are those who are over 40. It's dose related, so dose. It is the most severe of the hematologic reaction. So you need to star that little area that I've got there in italics. So instructed to immediately report rash, fever, sore throat, and flu-like symptoms. So the next thing you do is get a white blood cell count. Usually occurs early, first 3 months of therapy. Usually, remember, that's our highest dose, and then we're going to titrate it down. It's probably why you don't see it so much in long term. We do not do routine serial looking at you don't monitor white blood cell count, because it tends to happen abruptly. And it doesn't happen in 95% of people. So you're not going to monitor that when they come in to see you. If they're diagnosed, stop the drug, treat the infection. Usually the granulocytes will come back. If they die, it's due to the infection. You would never re-challenge them, and you would never use a thioamide in them again. Drug-induced hepatotoxicity. Again, PTU is the major problem here. So that's why this drug has gotten less favorability, plus the fact that it has to be dosed multiple times a day. So fulminant hepatic necrosis can be fatal. Methimazole is a different type of injury. It is more cholestatic. Again, first 3 months of therapy, higher doses. Risk is greater than in kids. Because on a weight basis, they're using more drug than adults do. Transient elevations in liver enzymes occur in about 30% of people. So you're going to watch those. If they're just going up, you're going to watch and see if they come down. Usually comes back to normal. But you want to tell them about these symptoms. If they develop symptoms of nausea, vomiting, diarrhea, fatigue, abdominal tenderness, They will quit eating. They will not be, they'll just feel so lethargic. Again, drugs should be stopped. You're not going to switch to another amide or re-challenge them. We don't recommend liver functions to be routinely monitored unless you already have somebody who has mild liver disease and this is the best option. Or maybe they refuse surgery or radioactive iodine. There are 3 exceptions when you would use PTU first line, and that is, again, first trimester of pregnancy, intolerance to methimazole, and thyroid storm. Be sure you know those. Other side effects are much less. There are arthralgias, lupus-like syndrome, polymyositis, so the muscle aches, and GI intolerance. Contraindications, previous adverse effects. So if you're going to start them on this, you want to ask them, have you ever been on this drug before? They're teratogenic, so you got to talk to women who are in reproductive age about using contraceptives and planning. And then long-term use in older patients with contraindications, surgery, or radioactive iodine. That is not a contraindication to be removed over. It's probably a drug of choice. Okay. Questions there. So now what you haven't heard about, but we haven't talked a lot about radioactive iodine. We'll do that, and then I'll see what you think. What would you choose? I know what I would do. So anyway, all right, let's take a break. We'll come back in 10 minutes.